So we know the most common diagnoses in lower limb pain in runners particularly because there's a reasonable amount of studies looked at those diagnoses. So we know anterior knee pain is common, Achilles tendinopathy is common, but if we confine ourselves to the shank or the lower leg, then we've got chronic exertional compartment syndrome, medial tibial stress, popliteal artery entrapment, and of course there's other neuropathies and myopathies that sit within that, but in terms of prevalence we'd be at medial tibial stress and then chronic exertional compartment syndrome, or those sort of things, top of the list. Differentiating between this set of lower limb injuries is a challenge because they often present very similar ways to the clinician. So we've got crescendo type pain, constricting type pain around the calf or the anterior shin, which ultimately stops the runner running. And whether the patient can run through it initially or otherwise, those symptoms can then develop to some pins and needles, some numbness, some foot drop. One of the really big things we can differentiate with though is the length of time of symptoms. So if you have night pain or the symptoms last overnight and particularly evident at night, then we think more towards the stress fracture than we would the others. Medial tibial stress we'd expect to settle reasonably quickly, but certainly within 24 hours or so of running. Chronic exertional compartment syndrome, often up to a week. Whereas popliteal artery entrapment syndrome, a very small percentage of patients really genuinely present with it, would resolve within minutes. There's obviously a role for imaging here, particularly in excluding a stress response or a stress fracture. X-ray might be optional in terms of a stress fracture, but clearly MRI is much more sensitive in looking at those early bone changes and making that differentiation between periostitis, a periosteal reaction in the medial tibial stress candidate, versus the actual fracture and the bone edema seen in a stress fracture proper. In terms of chronic exertional compartment syndrome, patients around the world are still subjected to compartment pressure studies, although we know certainly from recent work by Roscoe that the existing Pedowitz criteria of that threshold 1 minute and 5 minutes post-exercise, really we have to question as to whether we should be looking at intracompartmental pressures of 90 millimeters of mercury or more if we were going to do that test and make a recommendation of surgery. Popliteal artery entrapment syndrome really needs pressure studies or Doppler flow studies after exercise. So that set of tests can give us enough information to make that diagnosis, of course based on that clinical history. So recent biomechanical work really starts to highlight the role that joint kinematics, so the changes of angle of a joint, and kinetics, the amount of load that goes through those joints, can play in terms of these conditions. We have to consider whether in fact these are true pathology or whether or not this is actually just a muscle biomechanical overload. And so therefore you can see if we overstride, we reach the tibia out too far in front of the center of mass, we spend a long time in contact with the ground, or a significant knee flexion, or indeed significant hip flexion and torso lean, that we can distribute the load differently across the body. So it's not really as simple as a spring mass model where we expect the leg to compress underneath the runner, and there's much they can do in terms of transferring load proximally. Big muscles do big jobs, away from the smaller muscles. But then again, it's easy to forget the role of the plantar flexors, which are significant propulsion muscles. So understanding and looking at sagittal and coronal gait is really important in trying to understand where we might intervene with either a strength or a rate of force development intervention to try to make those changes. Outside of gait re-education, strength work is really probably one of the most sort of vital things we need to consider. Often a lot of these patients are really running at the edge of their capacity, so trying to build up some residual capacity in those patients to make that transition, be it for playing back-to-back games or taking on a tournament, is really important. There's some evidence to suggest that compression garments can help, particularly in terms of muscular pain, soleus and gastroc, and so a compression garment can be useful. But we're talking about ultimately diagnoses that have an intervention. So in terms of a stress fracture, we need to reduce load, we need to mitigate that, we might need to immobilize the shin in a boot, or in terms of popliteal artery entrapment syndrome, we may need ultimately to end up with surgery. I think one of the important things to mention though is that with chronic exertional compartment syndrome, with that question mark over that raised pressure, we should be very careful before sending off a patient for a fasciotomy or a fasciectomy, because the results of the studies in that don't really bear resemblance to those diagnostic pressures.